various theories, and how these factors they come into play, what are the causative factors, and those factors they will be guiding you how you have to treat. And we discussed different types of stones, how they are formed, and today we will be discussing various types of last time we discussed about various types of stones, and now we will discuss about how they present, how you will investigate, and how you will treat. Symptoms. So it is only accepted that these kidney stones, at least, they are formed in the upper proximal urinary tract, means in the renal parenchyma, and then they pass progressively into the calyces, then to the renal pelvis, then to the ureter, the urinary bladder, and then they pass through the urethra. So they are found basically in the proximal urinary tract. So these symptoms, they may start from the kidney itself, depending upon where they are detected, where they get impacted. So where they are situated, the symptoms, they will depend upon the situation of that calculus. So if they are in the renal parenchyma itself, or they are calyces, or they are in the renal pelvis or the ureter, or in the urinary bladder or urethra, symptoms, they will depend upon the site where these stones are lodged. So this is from your book. So this is the kidney, diagrammatic representation, the renal parenchyma. These are the calyces, pyramids, and these are the calyces. This is the renal pelvis, pelvic junction, the ureter, and then it is entering into the urinary bladder. So this is ureteric orifice. So there are 5 sites where these stones they can get impacted once they have crossed this renal pelvis. So first they are in the renal parenchyma, that is nephrolithiasis, then in the calyces, then in the renal pelvis, pelvic junction, the upper ureter, middle ureter, lower ureter, and then they can get impacted at these narrowings. They are normal anatomical narrowing. One is pelvic junction, then where this ureter crosses this iliac artery. So this is second constriction. Then when it is in relation to the vas deferens or the broad ligament. So in females it is broad ligament, in males it is vas deferens. So this is third constriction. And then at a place where this ureter enters the bladder wall at this level, and when it opens in the urothelium as ureteric orifice. So these are the 5 constrictions where these stones they can get impacted. So once it passes this, then it may reach here and then it can get closed here thereafter. This place, so these are 5 normal places where there are chances of impaction. In any case, they may get impacted here also. They may get impacted here also, but these are the normal anatomical locations where these stones they can get impacted. So presentation may vary from incidental radiopaque shadow. So you are investigating for some other disease, and incidentally you may discover that there is a radiopaque shadow in that genitourinary tract. And patient may not have any symptoms, or patient may develop fulminant pyelonephritis. Patient may be very sick. So obstruction will cause infection and it may cause sepsis. So the features, they will depend upon at what stage the patient is presenting. So if they are very small stones, they may be asymptomatic. So asymptomatic non-obstructive, if it is not causing any obstruction, it may remain asymptomatic, and they may be discovered incidentally for evaluating for other organs. On ultrasound and plain scaogram, you can detect about 80% of the stones, they are radiopaque, so you may detect on plain scaogram, or you are getting ultrasound for some other diseases or other conditions, then you can have the any urolithiasis on accidentally discovered these stones. So non-obstructive, generally asymptomatic, may come with gross hematuria. So large stones which block an infundibulum may cause flank pain, recurrent UTI, persistent hematuria. So these are the symptoms if they cause blockage of the infundibulum of the calyces. Flank pain and any obstruction will cause recurrent urinary tract infection and irritation. I told you that when these are mulberry type of stones, they cause this irritation because of epithelium. So they will cause hematuria and symptoms. Then small stones, they remain asymptomatic, but they may get impacted when they are disclosed to the ureteral junction. So if they are impacted, they will cause intermittent pain in the flank or the costovertebral angle. So this will depend upon whether it is causing obstruction or it is not causing any obstruction. So when there is obstruction, it may get superadd infection. So when there is infection in an obstructive system, then it will cause florid pyelonephritis and septicemia. Patient will have high swing fever with chills and rigors. So they may be investigating for some other pyrexia of unknown origin, but patient may have urinary tract symptoms. So small stones, they remain asymptomatic, but once it is causing obstruction, then it will be presenting as a pain. And if there is spread infection, they will have septicemia. So small stones, they may pass in the ureter, and depending upon where they have gone, they will have each peristalsis this ureteric colic and may manifest as hematuria. So the size of this ureter varies from where the stone is impacted. Beyond this upper part of this UPJ, this is about 10 millimeter diameter. So a small stone that can easily pass to the level of where this is crossing the iliac vessels. So second station will be block at this level. First is pelvic junction. So if the stone is less than 10 mm, that will go up to that place. Now it can get impacted there. Thereafter it will go to this extra position of where this vas deferens broad ligament is there. If that crosses that one also, then where it enters the urinary bladder. And if that also passes, we get impacted at vagino-ureteric junction. So it depends upon what is the size of the stone. So normally, if a small stone less than 5 millimeter, that may pass. But even if 1 millimeter stone may get impacted. So this will depend upon patient to patient. So if there is a stone in the upper ureter, when I was discussing about the symptoms, I told you that it will cause a spasmodic ureteric colic, typical ureteric colic due to obstruction of the ureter. This is because with each peristalsis, the ureteric muscle tries to get rid of this obstruction and it contracts, so that causes pain. So there will be sharp spasmodic pain in the flank. As the stone passes down to the level of pelvic ring, the pain remains sharp and intermittent, corresponding to the peristalsis of the ureter. And this pain frequently radiates. I told you that from loin to groin and then to the scrotal testis. So depending upon at which place the stone is there in the ureter, its radiation. I had already talked about various types of radiation, upper ureter, middle ureter, lower ureter, because of its nerve supply. So radiation will be there, but this will be typically sharp, spasmodic, intermittent pain corresponding with each peristalsis. Then there can be associated symptoms. I told you that because of pylorospasm, reflex pylorospasm, that will cause nausea and vomiting. This pain is intermittent, intense, episodic interval, and in between there are periods of relief. So then you have to differentiate this pain with other causes of pain. In patients of peritonitis, the patient doesn't get relief and they remain silent. But this ureteric spasmodic pain, patient tries to move in different bizarre positions just to get relief of the pain. So intermittent sharp pain corresponding with ureteric peristalsis is hallmark of this ureteric colic. This pain, it radiates along the inguinal canal to the groin, corresponding to the testicles in the males and labia in the females, and may have associated urinary symptoms. So this distal ureteral stone will radiate to these areas. And then if the stone is at vagico-ureteral junction, then it will present with features of vagical irritability, that urinary bladder irritability, more frequency they can have. So vagico-ureteral junction is narrow, it is about 1.5 mm. So if there is a big stone, it is likely to get impacted. So it is the site for impaction of the stone. So from stone, if it is coming down from the pelvis to pelvic junction, then it is likely to get impacted at ureterovagical junction. So it can get impacted there, and then it will cause hydroureteral nephrosis, and then it will manifest with symptoms of vagical irritability. And if it gets impacted, then there may be superadded pyelonephritis infection, and patient will have other symptoms of sepsis. So clinical examination is very essential in all these patients to rule out other conditions of the acute abdomen. I told you that there are so many differential diagnoses. So clinical diagnosis is very essential. Patient is in multiple bizarre positions to find relief from the severe pain. This will differentiate from peritonitis. A patient of peritonitis will lie still in the bed, will not move. Because if patient moves, that peritoneal irritation will cause pain. But here in this ureteric colic, patient tries to move in the bed or take different positions to get relief from it. So this is the difference between peritonitis pain and the pain of the ureteric colic. So they may have tachycardia, sweating, and nausea because of the symptoms associated with pain. And in examination, you will find costovertebral tenderness because of the hydronephrosis due to back pressure. Hydroureter will cause hydronephrosis. So kidney becomes tender, and if there is superadded infection, pyelonephritis, so it will be very tender. I showed you that Murphy's punch to demonstrate this costovertebral tenderness. So position, if the patient is very active in the bed, so it is unlikely to be peritonitis. More likely it is ureteric. So if there is long-standing obstruction, then kidney will get enlarged and then will find abdominal mass. So in the lump, bimanually palpable on that side on which there is stone or causing obstruction. So if there is urosepsis, means secondary infection, this patient will have high swinging fever, may have shock, hypotension, and vasodilation. So this is suggestive of gram-negative sepsis. Fever, high swinging fever, chills and rigors, hypertension. So you should always examine abdomen thoroughly to rule out other causes of acute abdomen, which may mimic ureteric colic. So abdominal exams is very essential, especially in females, to rule out pregnancy and all the other inflammatory diseases. course, acute appendicitis is very common on left side, but sometimes patient may have situs inversus and there can be appendix on the left side also. And bladder palpation to exclude acute urinary retention. Patient may have acute urinary retention. In that case, supraabdominal enlarged bladder may be seen. And always examine the digital rectal examination to find out any pathology in the anorectum. So clinical exams is of utmost importance to rule out kidney, to find out if there is other abdominal cause, if there is bladder full or it is empty, and rectal examination. So these are various sites where the stones are formed and then there is safe if they are. So if there is a stone in this calyces and pelvis, it will attain staghorn type. If it is in calyces, then shape will be different. So the pelvis, the shape is different. Ureter, because they are formed here like this. These are primarily formed in the bladder, especially in patients of benign prostatic hyperplasia or strictures here, then there can be different types of stones. So you have to differentiate the pain of urinary colic with appendicitis, peptic ulcer pain, then in females ectopic and unrecognized pregnancy. Of course, twisted ovarian cyst can present similar to the appendicitis and urinary colics of ovarian pathologies. Diverticulitis, more common in West, but still in India it can be there. Diverticulitis, intestinal obstruction, gallstone disease, sometimes biliary colic may be there, having pain in the right side. So symptoms wise it will be different, clinical exam will be different. So but pain can be due to appendicitis, peptic ulcer, biliary stones, in females, ectopic pregnancy, unrecognized pregnancy, ovarian pathologies. In both males and females, diverticulitis, bowel obstruction. Then there are other conditions which may have this acute abdomen, acute renal artery embolism, acute, causing obstruction and causing ischemia of the kidney, can cause pain. Dissecting aortic aneurysm, aortic dissection, can have catastrophic pain and patient may go in shock. Prolapse of the intervertebral disc, lumbar disc can have the similar pain. Then incarcerated inguinal hernia, epididymitis in males, orchitis, nephritis, all these can cause pain. So how you will investigate a patient of urinary stones? So it is very difficult. It is not so easy to find out why the patient has found stone. It is easy to detect that stone is there, but what is the cause? So then we have to go in detailed investigations to find out what is the probable cause, so that once you treat, then you have to prevent. Otherwise, patient will have recurrence, which I talked earlier. So urine examination is one important examination in all patients of uronithiasis, whether the patient has got urinary tract infection. If there is infection, then they will have recurrent, quick patent stones. So we have to treat that of infection. So these strips are available. You dip these strips in the urine and you will have this much investigation. Whether patient has got erythrocytes, leukocytes, nitrites, what is the pH, and if infection, then you do culture. So if the colony count is more than 10 raised to 5 colony per ml, then patient has got infection. Find out which microbe, specific antimicrobial, depending on culture sensitivity. So erythrocytes, they can be there in the urinary tract stones. If leukocytes are, it means this that there is either superadded infection. So when there is obstruction due to the stone, it will go secondarily infected. And nitrite positive says that there is infection. So if there is nitrite positive, you should subject it for urine culture. And microscopy can also show the pus cells. So pH, if it is more than 7, it means microbes which are especially Proteus mirabilis, urea splitting microbes, they cause infection and alkalinization. In these patients, we may have to do acidify the urine. If the pH is less than 6, I told you that uric acid stones, they are formed in the acidic medium. So in these patients, you may have to alkalize the urine. So simple strip test for the urine, early morning urine sample should be subjected for the examination, and you find out whether erythrocytes, leukocytes, nitrites, and that's at the same time you can subject this for microscopy to find out which type of crystals are there. I will show you that later. Then blood examination to find out what is the creatinine level, what is the urea level, and if there is infection, then total count, whether leukocytosis, whether left or receive. They will suggest you if creatinine is raised, it means there is impairment of the kidney function. There are two kidneys. If one kidney is, the other kidney will take over. But if the creatinine level is raised, it means there is significant effect on the kidneys. Bilateral kidney, they are affected. So if leukocytosis is this infection, left to the shift, this infection, and if associated thrombocytopenia, it's just sepsis. So TLC, DLC, serum creatinine, blood urea. So they are of very importance. So minimum analytical program in a patient of urinary stones is to find out that what is about the pH. So you repeat this pH. If constantly patient has got more than 5.8, then it can be renal tubular acidosis. And patient may have calcium oxalate or calcium phosphate stones. Similarly, if it is more than 7, so you have to repeat it several times a day. Because I told you that after meal it will become alkaline, if it's fasting, it will be different. So you examine this at several times a day of this several samples so that you can find out whether it is constantly at these levels. So if it is constantly, it means it is infection. And if it is infection, it is true white stone, or it can be calcium. So this pH will be very important in finding out what is the likely stone. So if it is less than 5.8 persistently acidic urine, patient will have uric acid stones. Similarly, in tuberculosis, there is acidic urine. But if the patient is having associated stones and urine is less than or equal to 5.8 persistently, it means patient has got uric acid stones. So you repeat this pH several times a day and find out whether it is constantly more than 5.8 or less than 5.8. Less than 5.8 it is uric acid stone, more than 5.8 calcium oxalate calcium. And if it is persistently more than 7, it means it is struvite stones, infection. And persistent erythrocytes means there is hematuria, so any stone can cause, all stones they will present with hematuria. If leukocytes, it means there is infection and it is infected stones. If nitrite, it also suggests infection. So leukocytes and nitrite, they will say that this is due to infective stones. And at the same time, you have to treat the infection. Urine culture will find out which microbes are there. Then you find out the specific gravity of it. So if it is persistently more than 1.010, indicates patient has got low fluid intake. Because if you take a lot of fluid, then this should be diluted also. Both kidneys, they concentrate, they try to conserve. If they conserve, it means patient has got low fluid intake. Otherwise, whatever if you take more, they will produce more urine. So all stone disease, they may have decrease fluid intake. So when we will be talking about treatment, we will advise that they should take a lot of fluids. So then erythrocytes are present. So any mucosal lesion that is due to infection, glomerularitis, so they will cause all these stones, they will cause erythrocytes, leukocytes for all infections, and bacteria if positive. And in cystine test, it's positive. This is for specifically for cystine urine cystine. So urine has to be subjected for these tests, and blood to find out whether patient has got hypercalcemia, especially patients of parathormone, suspected hyperparathyroidism. So they will have calcium oxalate, calcium phosphorus stones. If patient has got hyperuricemia in gouts, they will have uric acid stones. So urate level and creatinine is increased, means kidneys they are impaired. So creatinine they will be raised when the kidney function is impaired. So as a team here, you will find out in these patients. So irrespective of the stone, which type of stone is there, at least you should investigate 24-hour urine variables. So what is the 24 hours urine profile? So pH, whether it is less than 5.8 or more than 6.8. Then specific gravity of the morning urine sample. If it is more than 1.010, total volume less than 2 liter or more than 2 liter. Calcium 24 hours more than 5 millimole or more than 8 millimole. If it is more than 8 millimole per liter, it is defined as hypercalciuria. Similarly, uric acid levels, citrate level, oxalate level, creatinine. This estimation in 24-hour urine should be done. In addition, you should perform magnesium, inorganic phosphate, ammonium, and citrate. So 24 hours urine, whether they are stone form or whether there is some abnormality or not. So some of the patients may not find gross abnormality, still they form this stone, but some of the patients will have this tendency. So in those patients, you may have to alter the dietetic and other things. Similarly, blood examination, compulsory. You should always rule out hypercalcemia. So serum calcium, uric acid, phosphate, and creatinine to find out the status of the kidney, whether they are impaired or not. So if there is hypercalcemia, then optional is PTH. If hypercalcemia, definitely you should get PTH. But even if it is normal, then it's optional, you may get it. And then blood gases to find out renal tubular acidosis. So blood gas, arterial blood gas, pH, oxygen, PO2, bicarb, base excess. So you have to get at least 24-hour urine investigation for these things and blood examination for calcium, uric acid, phosphorus, and calcium. And of course, optional PTH and blood gas. This investigation will guide you which type of stone the patient is forming so that future alteration for avoiding recurrence. So what you expect, you should note down this, you will not find your books. That in uric acid stones, you will find that urinary pH is acidic, less than 6. And urinary uric acid is increased. And serum uric acid is increased. It means they will have uric acid stones. So U stands for urine exam, S for serum, blood examination. Similarly, in calcium oxalate stones, urinary pH may be low or it may be normal, but you will find increased urinary calcium excretion. And this citrate, which I told you, is protective. So urinary citrate decrease in those patients. Urinary urate is increased, oxalate is increased, and magnesium is another which is protective, that is also decreased. So this protective urinary citrate and magnesium, they are decreased, whereas calcium, urate, and oxalate are increased. Similarly, calcium phosphate stones, both calcium and phosphate in the urine are increased. Urinary pH is never less than 5.8. So it is RT or infection. Serum calcium will be increased. So serum calcium is increased, that's why urinary calcium is also increased. And they have got in addition urinary phosphate increased. That's why they will have calcium phosphate stones. Struvite stones, infective stones. Here you will find urinary pH is always more than 7, and mostly urea is producing microbes like Proteus mirabilis. So urine ammonia is increased, citrate is protected, that is decreased. So you will find in culture, you will find microbes. Then cystine stones, urinary cystine levels they will be increased. Xanthine stones, urate will be decreased. In ammonium urate stones, pH 6.5 to 7, ammonia will be increased and phosphate will be decreased. This is how you will interpret the results of urinary levels of these very signs and pH and serum levels to detect which type of stone the patient is harboring. So these are various on microscopy examination. I told you earlier how they look like. Their examination, these are rhomboid plates in the uric acid stones, barrel shaped. So these are the stones which can be diagnosed by pathologist who is examining this. Dumbbell shape, struvite infection stones. So this is just with the appearance that which stones are there. So pathologist can tell you just seeing under the microscope that these stones are due to this crystals of in the urine. So after urine, blood and microscopy and culture, you will proceed for this radiological examination. Ultrasonography is a good investigation. Doesn't cause any radiation, comparatively cheap, readily available, portable, can be done in patients who are pregnant, causing no ionizing radiation. So this ultrasound is good investigation. This can tell you about the site, size, number of stones, where they are situated, whether they are in the kidney or the calyces or pelvis or ureter. So this is good for kidney and pelvis, but not so good for ureter and down because the gas shadow, they prevent their detection, but it will tell you the dilatation of the ureter. The site it can tell. So where is the obstruction? It exactly can tell about the size. It can detect about urinary bladder stones. If bladder is full, it can easily find out the stone in the, and of course in the urethra also. So ultrasound is very good investigation. KUV film I already discussed when I was talking about these investigations. So about 80% of the stones, they are radiopaque, so you can detect this. And how you do it, I told you that you have to prepare a good film by preparing the abdomen. So overnight fasting, patient on collection charcoal to absorb the gases and clear the feces. And then you take this diagram from G5 sternum to the pelvis, pubic symphysis. So that is a KUV film and you will find radiopaque shadow. So 20% of stone they will be missed because they are radiolucent, but 80% you will find out. So if you have some confusion, then this intravenous urography. These days we avoid this investigation because this dye itself causes anaphylaxis and it is nephrotoxic also. But in situations where you are not able to exactly detect where the stones are, and if you want to operate, then this investigation is very good. Or where ultrasound is not good or operator is not so sure where it is there, then intravenous urography. Spiral CT scan is the investigation of choice these days for the urinary stones, so it will detect all these stones. Non-contrast CT scan will detect the urolithiasis. Then Retrograde pylography, we will talk, when we were talking about this investigation, I talked about this retrograde pylography to find out where the stones are. Nuclear scintigraphy to find out if the kidney is functioning or it is non-functioning. If it is non-functioning, there is no role of removing the stones, then you may have to remove the kidney. So this nuclear scintigraphy, radioisotope scan will tell you about the differential function of the kidney. So if it is more than 10%, then we preserve. If it is less than 10%, then it is better to remove the kidney, that if other kidney is normal. And of course, tomography, that can help to find out where exactly the stone in the renal parenchyma. So these are different investigations. This is how these calculi look like on ultrasound. I showed you this investigation when I was talking about various investigation in the urinary tract disease. So I will not go much in detail. These are different plain skygram. Plain skygram, bilateral staghorse white stones, plain skygram. There is no intravenous urogram. It's plain skygram, bilateral multiple stones. There is also renal tubular acidosis, multiple calcification, bilateral kidney. This is also plain skygram, malrotated kidney. This IVU film, because we are tracing this plain skygram. This IVU film to find out this shadow is noted in the kidney. So this is in the collecting system. This is how ureteric stone, this is causing obstruction. So there is a stone here. This is stone passing alongside this ureter. This is stone. So treatment will depend upon what the size, how it is causing the changes in the urinary tract. So most ureteral stones, they pass spontaneously. But the spontaneous passage of the stone will depend upon its size, shape, location, and ureterality. A very big size, if it say 2 centimeter stone, it will not pass because the caliber of the ureter is not 2 centimeter. Its shape, if it is smooth, it can pass. But if it is mulberry type, it will get impacted somewhere because of its spicules. So shape is very important, and location. If at presentation, this stone is at upper urinary tract, say in the pelvis or the upper ureter, then there are less chances of spontaneous passage because it is likely to get infected because it has become symptomatic at early stage. If at presentation the stone has lower part, then it is likely to get spontaneously passed. Similarly, if there is a lot of ureteral edema, it will not allow the stone to pass because it will cause obstruction and infection. So if small stones, they will pass spontaneously. If large, they will get infected. And this passage, spontaneous passage, will depend upon size, shape, location, and ureteral edema. So spontaneous passage unpredictable. Usually 4 to 5 mm size of ureteric calculi, they have got 40 to 50% chances of spontaneous passage. So about 50% of these will pass spontaneously, and rest will get impacted. So if the size is more than 6 millimeter, then less than 5% of the stone they will pass, and all of other they will get impacted. So they will need intervention, surgical intervention. But at times, even 10 mm stone in some patient may pass occasionally. So you cannot specifically say that this will get impacted, this will not, but by and large, if it is more than 6, 7, less chances of passage. If it is less than 4, there are more chances. But 4 to 5 or 50% will pass. And 1 to 2 at times may get impacted at vesico-ureteric junction. So in 1 to 2 millimeter stones may also get impacted. So with confidence, you can't say that this stone will pass and this will pass. But more than 10, usually they will not pass. And if the shape is speculated, they will not pass. And if at presentation they are at higher level, they are likely to get infected. So most of the stones that pass, they pass within 6 weeks of presentation of symptoms. So if they present to be urinary colic, so if it has to pass, this will pass within 6 weeks. If it has not passed within 6 weeks, it is likely to get infected. Ureteric calculi which are discovered in the distal ureter, means lower ureter. So they are having about 50% of chance of spontaneous passage, means it has traveled a lot, so it may pass off. But if at presentation they are in the mid-ureter, then about 25% of the stone they will pass, otherwise they will get infected. And more proximal stones, they have got only 10% chances of spontaneous passage. It means more proximal the stone means upper ureter or vaginal ureter, that less chances of spontaneous passage. If at present is at lower level, say lower ureter or vaginal ureter, then more chances. So usually, if it has to pass spontaneously, it will pass within 6 weeks. If it has not passed, it means it is infected stone. Now you have to intervene and remove it. How you will manage? So one is dietetic. So with your exam of urine and blood, you will find out what are of the stone. Then you will avoid those things which cause increased levels of those ions. But in patients, you advise fresh fruits, fresh vegetables and salads, whole grain products, plant fat, low fat dairy products. Because dairy products, they increase the chance of increased calcium and stones. So you recommend these. And you restrict their intake of meat, fish, and sausage, because they will cause more increased levels of calcium. Then, during diet, you avoid high fat content or high sugar or too much salt. So they should not take much fat, sugar, and salt. Reduce their energy intake and distribute this intake of food to several small. So they should have frequent small meals, and they should not take excessive fat, additional sugar, salt. They should avoid. Fluid intake should be sufficient to have good urinary output, and this should be 24 hours spaced. Some people, they just take this water in the morning hours, and rest of the time their kidneys, they are dehydrated, so they will form stones. So you take at least 2 to 3 liters evenly distributed fluid during 24 hours. So suitable beverages are mineral water with low mineral salts, kidney tea, bladder tea, fruit tea. There are different types of teas, they are available in the market. So they can use this kidney tea, bladder tea, fruit tea, diet purposes. These are good for patients who form stones. So they will prevent the stones. But less suitable are, they should not take black tea, coffee, lemonades with sugar, cola drinks, alcohol drinks. All these cause increased chances of urolithiasis. So they should not take these. Beer is not a therapeutic agent. Some people have misconceived that beer will treat, though this will cause diarrhea, but they will not decrease the stone formation. So you take a lot of fluids and reduce overweight. Practice physical activities, but not to the extent that excess is sweating. If there is excessive, you should take adequate water. Water should be replaced. Avoid stress, and you should have sufficient sleep. So there should be general change in the patient activities. So if there is obstruction, you have to remove that stone at the earliest. Otherwise, it will cause morbidity, it will cause infection, pyelonephritis, and loss of kidney function, and in some cases, even mortality. So whenever there is impacted stone, you have to remove it at the earliest. Obstructing stones, if ureter, you can put a double J stent or percutaneous nephrostomy. So you have to remove the obstruction. Then there are certain dissolution therapy. You can dissolve the stone, means conservative management. depend upon the stone type, surface and volume. Uric acid and cystine stones, they will dissolve with the change of the pH. So you can change the pH to the alkaline in uric acid and cystine stones, so they will get dissolved. So this graph I showed you earlier, that uric acid and cystine, they will dissolve if you make the urine alkaline. These in this acidic. So change the pH. So infected stone will acidify. In this stone, you alkalize. So dissolution therapy, you can put these dissolution solutions through the nephrostomy tube or by the catheter. You can dissolve. Similarly, cystine stone, they dissolve with dipenicillamine and acetyl cystine. So dissolution therapy is one. Steroid stone, they require acidification of the urine by this solution. So VG solution or hemiacidrin. So change the pH. So if they are not amenable to conservative, then you can break these stones by extracorporeal shock wave lithotripsy, ESW. We have got this instrument in the urology. This will break the stone and that stone will be passed in the urine. So this is how it is acting. You produce these shock waves, you focus this on the stone. So these compression waves, they will cause erosion of the stone, settling the stone and erosion. So this big stone will get fragmented into small pieces and then through the ureter, through the bladder, they will be excreted in the urine. Extracorporeal shock wave lithotripsy. So all shock waves, irrespective of their source, can fragment stones when focused on that stone. Fragmentation is achieved by erosion and shattering. Cavitational forces cause erosion at the entry and exit site of the shock waves. And shattering results from energy absorption with stress, strain and shear forces. So they will ultimately cause fragmentation of the stone, and surrounding tissues are resilient as they are not brittle and are not focused. So this will not cause injury to other organs. It will break the stone if you are properly focused the stone. So if they are not amenable to ESWL, then there is another more minimal invasive technique, percutaneous nephrolithotomy. Percutaneous nephrolithotomy. So this is the treatment choice in kidney and proximal ureteric stone of more than 2.5 centimeter size, which are resistant to ESWL. If they are not broken with this ESWL, you can use this PSML. So how you do it? With ultrasound guided, fluoroscopy guided, you will first puncture into the posterior inferior calyx via posterior axillary line. So through the skin, you will make a needle puncture and you will enter this posterior inferior calyces. Then with the dilators, you will dilate this tract, and through those dilatoplasty dilators, you will put your telescope, Wedel dilator, and then you dilate with the balloon dilatation. So this may require several settings, and then you will enter that. This is the stone. With puncture, you will enter there, and with this nephroscope, you can remove this stone. So this stone, you can use the lithotripter, you can put there and you can break the stone. And with the grasper, you can remove the stones. So this is how you do this percutaneous nephrolithotomy. Then if they are not amenable to this, then open. This is for this ureteric stone, Dormia basket. These days we don't use this. Now they are flexible and other. So this is through the urethra, through the bladder, through the vascular junction, you pass this basket across that stone. And now you open this. This stone will get engaged in this basket and then you put. So you will remove through the cystoscope, cystourethroskop. This is by Dormia basket. But if they are not amenable to this endourological procedure, then you do open surgical procedure. Open pyelolithotomy means removal of this stone from the urinary pelvis. Extended pyelolithotomy in patients who have got intrarenal pelvis, in those we do extended pyelolithotomy, that is Gilverne technique. If the stone they are in the kidney parenchyma, then we do inotropic, means you are not causing injury to the cells. So you go through the avascular plane in the kidney and make incision in the kidney, nephrolethotomy. Then radial nephrotomy, that is also part of this. Stone removed from the kidney. Similarly, if kidney is not functioning, especially the lower pole, then you can remove those stone along with the partial nephrectomy. If kidney is not functioning at all, non-functioning kidney, another kidney normal, in that situation you remove the kidney, infected kidney. Non-functioning kidney can be removed, that is nephrectomy. And if the stone is there in the ureter and not removable with ureteroscope, then you will remove with ureterolithotomy, open. So now you please mark your present and leave the class.